I'm so delighted that each of you could come today. My name is Dean Ora Strickland, Dean of the Nicole Wertheim College of Nursing and Health Sciences. We have people who are in attendance in this room, and those individuals include the members of our Nursing Advisory Council. Let me say to you, thank you for coming. I know many of you are very busy. Many of you had to leave your hospitals where you are chief nursing officers or vice presidents of nursing and leaders around the Miami community in nursing. I want you to know how much we appreciate you coming and assisting us. I would also like to welcome the faculty who are tuned in and watching from our Biscayne Bay campus. Also, let me extend a special welcome to Erica Wertheim Zohar and Vanessa Wertheim, who are on the line and listening in. Thank you all for coming today. I would like to start the meeting with a very special announcement. As many of you are aware, we've had a lot of wonderful things that have happened to us in the past year, among which has been the Wertheim gift of $10 million, which named the College of Nursing and Health Sciences, and our new name is the Nicole Wertheim College of Nursing and Health Sciences. So we're very pleased and very excited about that. A little bit later, I'm going to be giving you more details on how the Wertheim gift will be used. But right now, I have a very important announcement to make, which is happening because of the Wertheim gift. Today, I would like for you to know that Dr. Joann Youngblut, an internationally renowned nurse researcher, will be the first faculty member to receive an endowed chair in the Nicole Wertheim College of Nursing and Health Sciences, and she will sit in the Dr. Herbert and Nicole Wertheim Endowed Chair in Prevention and Family Health. Joann is going to present in a few minutes, but she has had a very important and special mentor in her life, who is also her research partner. And I thought that it was only fitting that Dr. Dottie Bruton come forward and introduce Joann as she gives the announcement lecture, which will be very brief, in response to the naming of her to be the first endowed chair in the College of Nursing and Health Sciences. Dr. Dottie Bruton.
Thank you, Dean Strickland, for this honor and the opportunity to do this. I'm not sure who was the mentor and who was the mentee, because I joined Joann at Case Western Reserve University when she was already up and running and a well-known researcher. I want to begin by saying that investment in a named professorship is an investment in the university, in the college, and in the individual to carry forth the vision, the work, and the legacy in the area of the professorship. Meet Joann M. Youngblut. Dr. Youngblut has described herself as a pediatric critical care nurse who cared for children, but whose deep and lasting concerns were for the families who would ultimately care for the children that she'd been caring for. Those children born too soon, born with genetic insults, those suffering from accidents, traumatic brain injuries, and those children who ultimately died. Her concern was, what happens to these families? How can their pain be minimized? How can they be strengthened and protected so they can care for each other and for their remaining children? Dr. Youngblut's clinical passion and expertise was translated into research to improve the care of families. Before welfare reform, she studied, would mother's employment affect the growth and development of children born too soon, and what was the effect on the family? What were the effects of the child's traumatic brain injury on the child and on the family? And a body of research on the health and functioning of grandparents and parents who lost a child, and currently, the health and functioning of siblings who've lost a brother or sister. To date, the research study she has headed, funded by the NIH, private industry, and professional organizations, have totaled $7.5 million, plus another $6 million for those studies in which she has served as a co-investigator. And she's also headed training grants to improve family and children's health for another $1 million. Findings from her research studies have been published in over 80 journal articles and many, many other abstracts and proceedings. She has published in major medical and interdisciplinary journals, including Pediatrics, Pediatric Critical Care Medicine, American Journal of Hospice and Palliative Medicine, Psychology of Women Quarterly, Healthcare for Women International, the American Journal of Managed Care, the Journal of Pediatric Psychology, and the Journal of Head Trauma Rehab, among many others. She's published in all major nursing journals: Nursing Research, Research in Nursing and Health, the Journal of Nursing Scholarship, Nursing Outlook, American Journal of Critical Care, Heart and Lung, Journal of Nursing Measurement, the Thai Journal of Nursing Research, and the International Journal of Nursing Studies, among many others. She has presented her research nationally and globally. She served as a reviewer for the NIH for grant proposals, the Canadian Institutes of Health Research, the American Nurses Foundation, and the Health Foundation of South Florida. Dr. Youngblut has chaired 14 doctoral dissertations and been a member of 20 others. She has sponsored or co-sponsored 4 NIH-funded pre-doctoral fellowships and has mentored postdoctoral fellows and junior faculty. Her mentees are now academic leaders in Thailand, Korea, Zimbabwe, Egypt, Jordan, Canada, and all over the United States. Her work has been acknowledged by election into the American Academy of Nursing. She has received the Southern Nursing Research Society Distinguished Researcher Award, the FIU Faculty Excellence in Research Award, the Florida Nurses Association Research Award, the Ohio Nurses Association Research Award, the March of Dimes Nurse of the Year Award, and the University Distinguished Alumni Award from Indiana University of Pennsylvania, among others. As I look over the national and international landscape in the area of family health and prevention, I know of no one who comes close to the promise of carrying forth the legacy of this professorship, the Herbert and Nicole Wertheim Professorship in Prevention and Family Health that will support and care for families. And Dr. Joann M. Youngblut. Thank you.
Before you begin your presentation, this is just a token of our pride in the work of Dr. Joann Youngblut. Thank you. I have to find it first. Oh, there it is. Okay. Cool. Is the keyboard? Oh, I have to use it quickly? Okay. So just, which one? Oh, okay. Okay, got it. Okay. Thank you very much, Dean Strickland and Dr. Bruton, for those very kind words. We have a very short time today, so I'd like to talk with you about the most recent studies that we've been conducting, focused on children, on parent and grandparent and sibling functioning and health after the death of a child, most of them in the ICU. And so the question is, children with critical illness and death, what happens to the family? We've seen that worried or distressed look in parents' eyes. We wonder how the family will cope with the child's death and what will happen to the parents and the family unit. Friends and relatives help and support the family, checking on them often for the first week or two after the death. Then they go back to their own lives and leave the parents alone to grieve, to pick up their lives and responsibilities, take care of their other children, and return to work. Grandparents worry about their adult child, the parent of the child that died, and surviving children are often left to fend for themselves. Dimensions of family health, since this is for prevention of family health, I think of three things in family health. First is the health of family members, which you can, most people would think about that. But also the quality of the family relationships and the family's ability to fulfill its functions. The family has to provide shelter, clothing, food, affection, comfort, security, socialization, and transmission of family values, culture, and history. In our study of parents whose child died in the intensive care unit, either the neonatal or pediatric intensive care unit, we have 249 parents of 185 children. And these are some of our findings. In terms of physical health, the parents reported 132 newly diagnosed chronic conditions. That's in addition to the ones that were pre-existing. So that doubled the number of chronic conditions that these parents had. And you'll remember, when you think about it, these parents were in their 20s and 30s. So they're young parents. 98 hospitalizations for 63 parents. Changes in medication regimen to control their chronic conditions. And then also mental health problems. 30 to 35% continue to have clinical depression and PTSD at 13 months post-death. Parent and family relationships at 6 months, and these parents reported that they were less affectionate as a couple, and their families were less cohesive at 6 months. Primarily for parents who have moderate to severe depression or PTSD at 1 month, but also for mothers who continue to have moderate to severe depression at 6 months. We didn't find any differences by deceased child's age, mode of death, NICU-PICU, and whether the death was expected. So what about grandparents? In our study of grandparents, we have 159 grandparents of 115 deceased grandchildren. This is a one-time study, and grandparents were interviewed sometime between 1 and 6 months post-death. And these are young grandchildren, under 6. Physical health, again, 70 illnesses since the child's death for 47 grandparents, 10 hospitalizations for 8 grandparents, and 244 chronic health conditions. Given the age of the grandparents, most of these were pre-existing, but some were newly diagnosed. Mental health looks very similar to the parents. 32% had clinical depression,
and 36% had clinical PTSD at 6 months. When we looked at the grandparent couple relationship, we didn't find any difference for any of these factors. There was no difference by grandparent gender, by the grandparent's race, ethnicity, how much child care they provided for the child before he or she died, and whether the death was expected, similar to the parents. And then what about the family's other children? This is a study that we're in the process of completing now. We're in the third or fourth year of turning into a 6-year grant. Sibling death during childhood means a loss of a playmate, a confidant, a friend, and a role model. It also means loss of parents, because their grief is so great that it leaves them with very little or no energy to reach out to their surviving children. So the children must deal with their own grief, their parents' grief, and a changed environment simultaneously. 50% have emotional and behavioral problems that require intervention, but very few get what they need. You do see developmental differences, as you might expect. Preschool and school-age children generally have a lack of understanding about death, both its permanence and what happens when someone dies. They're more likely to have behavioral problems than adolescents, and they're fearful for themselves. They're actually fearful that they might die. For adolescents, adolescents like to be cool. They don't want to show strong emotions. Yet their grief is more intense, intermittent, and overwhelming compared to that of parents and other adults. And at the same time, adolescents are expected to be more mature. In our parent study, we did some qualitative interviews with a subset of 63 parents. And this is some of the things that they talked about in regards to their other children. We have 6 themes that came out of what they talked about. First is changed behaviors. They talked about their children being distant, not talking, crying, avoiding things that they shared with their sibling, and needing time alone for their own recovery and grief and grieving. They talked about the children not feeling like they didn't have enough time with the sibling, wishing they had spent more time playing or reading or whatever with the sibling, taking care of the sibling, and more time to say goodbye. Also, they talked about children not understanding what's happening. That's not surprising given what we said in the last slide. And that's primarily for the preschoolers. Parents' comments also fell into maintaining a connection. Children talked about seeing and talking to their sibling, about wearing a special piece of clothing or a pin that reminded them of that child, and of dreams where they could interact with their deceased sibling. Some parents talked about believing the sibling is in a good place, mostly in heaven with God, and then not believing that the sibling would die. And that was across the age range, which surprised me. I thought that would be younger kids, but you'll see a quote from a 15-year-old. Here's some quotes from their comments. One said, the child told her that, "I see my sibling smiling outside the window at school. My daughter sleeps at her father's house. She's scared to sleep here since her sibling died. My son used to play the guitar for his sibling. He won't play anymore. He says it has no meaning now. It's as if he doesn't want to be around me, like he's in his own world. She, the 15-year-old, just doesn't want to accept that he's not coming back. Relatives often say to the children, you must be strong for your parents. And children say, don't be sad, you still have me." So what can we do? First, identify those at risk for greater grief and depression. In our samples, for parents, that means the single parents, parents who were Black or Hispanic, if they had a death of an adolescent versus other age groups, and if the treatment was limited or withdrawn. And for grandparents, it means grandparents who took care of the grandchild before death in any capacity, just babysitting versus full custody. Healthcare providers can help around the time of death, but they need to know what helped. These are things that our parents told us. Was helpful when they had compassionate, sensitive, experienced, competent healthcare providers taking care of their child. When they got understandable explanations of the child's condition, and when they were involved in the care decisions regarding the child. What didn't help? Conflict between the providers and the parents. This happens a lot in the ICU when the physicians or the healthcare providers would like to take someone off a ventilator and the parents aren't willing to do that. Very difficult thing to have a conflict around. They also talked about communication problems around the death and not understanding their child's disease, its care and its complications. The research is really scant. There have been some studies about children and family members responding to the death of kids from cancer. But that's a very different situation than a child dying in an intensive care unit. Many of these studies ask the parents or the children, who are now adults, to look back up to 40 years ago. So they're interviewing 40 years after the child died. And they have very biased samples. They recruit their participants from support groups, from psychiatric practices, and advertisements. Now certainly a parent who responds to an advertisement 40 years after their child died is different than one who doesn't respond. And so that we know that there are some long-term things, but we really don't know what gets them there. And of course, most of the samples are mainly white and mothers. So much more research is needed. Family dynamics, in summary, after a child's death, the family has changed forever. Our parents reported physical and mental health effects. The parents were less affectionate as a couple, and the families were less cohesive. Children revisit the death as they mature. Grandparents feel guilty that the grandchild died before them, and there's really no culture or space for their grief. The society doesn't recognize that. And I want to thank you for listening, and also to thank Dr. and Mrs. Wertheim for this wonderful honor and opportunity. And to acknowledge my husband, Bill, who's in the audience.
And once again, we are so proud of you, Joann. Thank you, that was a wonderful presentation. Now remember, that was just a small overview of some of her results. Her results are very voluminous and published in over 80 professional articles. Thank you, Joann.